Okay, we can start the second part of the meeting with the talk of Gianluca Merlo. This part of this presentation introduces the use of functional analysis in school setting and give us an overview of how teacher, expert and operator can interview in school setting. Okay, thank you.
Good morning. My name is Gianluca Merlo and I'm a researcher at Istituto per le Tecnologie Didattiche since 2009. I'm a psychologist, but I'm very passionate in new technologies and I'm pretty expert also in web programming. The topic of my presentation is about the ADHD at school. Why this matter? Students with ADHD have difficulty to sustaining attention to tasks. They play with objects during classes. They call out. Sometimes they are also aggressive. And so, as a consequence, children with ADHD frequently do poorly in school. And they are more likely to have physical problems than other children. They have increased difficulties with peer acceptance, and they are more likely to be anxious or depressed. So the question is how to manage unwanted behaviors at school and at home. You need an action plan. This action plan could be composed by 4 different steps. First of all, you have to identify a target behavior, or many target behaviors, and a desired direction of change. Once a target behavior is defined, you can start a functional assessment, then define a treatment and implement it, and finally you have to evaluate the efficacy of the treatment. But you have to evaluate this efficacy in a statistical manner. So let's see these different points. First of all, as I told you before, you need to identify target behaviors. So this means to define specific behaviors, define these behaviors in details. For instance, yelling could be defined as a vocal utterances above a normal tone of voice, and choice also which is a possible alternate response. So, for instance, in this case, it could be a raise hands or other behaviors. Once target behaviors are defined, it is possible to choose a type of intervention and also to predict which kind of desired modification the treatment could support, could improve, could enhance. Then you have to proceed with functional assessment. What is functional assessment? Functional assessment is defined as the use of multiple assessment strategies in order to delineate specific antecedent and consequent events that set the occasion for and or maintain a target behavior. This approach is very different from the so-called static assessment, because in the static assessment, every behavior, many behaviors look similar, and the way in which you treat a behavior is the same. In the functional assessment, every behavior has a specific function, and every behavior occurs in a specific context. So there are a lot of individual differences between pupils, between students, and obviously every behavior has to be evaluated in details in regard to a function or a context. But which are the most common function of ADHD behavior? The most common function of ADHD behavior are avoid or escape effortful tasks. A second possible function is to gain adult or peer attention. For instance, a frequent consequent event for ADHD behavior in the classroom is a verbal reprimand from the teacher or a non-verbal and verbal reaction from peers. An additional possible function is to assess a reinforcing object or a reinforcing activity that could be not the educational activity, obviously. We have also non-social behaviors. Non-social behaviors are sensory stimulation, like a student that is losing himself in their thoughts, in their pleasantful thoughts. And finally, obviously, there are behaviors that can be aimed to reduce physical discomfort, such as pain. So, how to identify the function of a behavior at school or at home? The most accurate way is the experimental functional analysis. The experimental functional analysis is a protocol defined by Iwata while he was studying self-injurious behavior. This kind of assessment occurs in a very controlled environment in which the experimenter manipulates many different conditions in a random multi-element design. So he manipulates conditions to evaluate which is the behavioral response and to identify the real function of a behavior. Manipulating the behavior, it is possible to generate hypotheses about the function or the functions maintaining a specific unwanted behaviors or unwanted behavior. Obviously, this method is a very good method to infer causation, but this is not feasible at school or at home because it requires very expert practitioners, and you have to also in some cases you risk to increase the unwanted behavior. So this is obviously not feasible at school or at home. Yeah. Another way to assess the function of a behavior are direct methods. In direct methods, these behaviors are also observed in a natural environment without a direct manipulation of the behavior. These methods have a high ecological validity, but these methods are based only on correlational data. So you observe a behavior in a time, And obviously, if the behavior occurs at low frequencies, you are not able to track this kind of data. Let's see some example of the direct methods. One of the most common direct methods is creating scatter plot. Scatter plots are visual representation of data collected by defining a specific interval and then obtaining information on the frequency and duration of behaviors. So for instance, in this graph, you can see that the unwanted behavior occurs more between 1 o'clock and 3 o'clock. And so you can, this is a clue, because you can formulate a hypothesis about what is happening in that time, in that time interval. Scatter plots are simple to be collected, but obviously you can gather only little information about antecedents and consequences. And so this is just partly feasible at school or at home. A second very common method, direct method, is ABC charts. In ABC charts, the observer collects data on A, the antecedents, B, behaviors, and C, consequences. This is an example of a possible sheet to, that the observer can fill in with data. So as you can see, this is very simple, and obviously this can be used at school from teachers or at home by parents. And you can gather a lot of information about events. So you can connect a behavior with antecedents and consequences. The problem with this kind of method is that it's really time-consuming. You have to spend a lot of time to track a lot of information. And obviously, this kind of information can be contaminated by subjective information. So ABC charts could be improved if there are multiple observers and several contexts of information. But for these reasons, also this method is only partly feasible at school or at home. Then we have indirect methods, where information is gathered by third party, such as parents, caregivers, or teachers. The idea behind this method is that this method not requires a direct observation, so it's easier than direct methods, is less intrusive, because you already know your student and you have not the need to observe the student during the unwanted behavior. And obviously this is usable over a long period of time. Let's see some example. One common indirect method is a functional interview. Functional interview is a tool to collect several variables about a behavior. For instance, the topography, the communication skills of the students, the existence of eventually previous treatment, and so on. This is a list of some functional interview available in literature, but we will concentrate our attention on this one, the functional assessment checklist for teachers and staff. This tool requires just 25 minutes to be completed and consists of two different parts. The part A is aimed to identify problem behaviors, to identify which are the student activities and the associated problem behaviors. Differently, the part B is more focused on the definition of the problem behavior and the definition of setting events, antecedents, and maintaining function. This is a picture of the part A, so the part in which you can gather information about the problem behavior. For instance, in which activity, which frequencies, and so on. And this is an example of the part B. So, for instance, you can see the item and say, what are the events that predict when the problem behavior will occur? So we are working on antecedent of the unwanted behavior. This method is obviously pretty feasible at school, but unfortunately, only a few studies demonstrating its validity from a statistical point of view. Finally, we have indirect methods, including informant-based scales. Informant-based scales are scales providing questions regarding the function of behaviors on a Likert type scales. So these kind of scales have a huge advantage. They can be administered in a really short time and can be scored and interpreted very easily. This is a list of some existing informant-based scales. But at this moment, the most accurate rating scale to infer the function of a behavior is the questions about behavior function by Matson and Vollmer. This scale is designed to aid in determining the function of challenging behaviors by gaining information from informants, such as parents or caregivers. QABF consists of 25 items on a 4-point anchored Likert scale. So never, rarely, some, or often. And QABF measure 5 subscales: attention, escape, physical, tangible, and non-social behaviors. This is an example of the QABF items. Teachers or parents have to estimate the frequency in which the student engage in many different types of behaviors. For instance, a couple of the items are the student engages in the behavior to get attention, or the student engage in the behavior to escape work or learning situation, and so on. Obviously, these items are related to the factors and dimensions that I told you before. Attention, escape, physical, tangible, and non-social. So at the end, we can have an idea of which is or which are the most maintaining functions for an unwanted behavior. As you can imagine, this is one of the most feasible methods at home or at school. Once we identified the functions related to unwanted behavior, it is possible to plan a treatment and implement it. Obviously, I will run very fast about this issue because my colleagues have already told you previously something about the treatment. So, what kind of treatment? As already you know, the best treatment is multimodal interventions, and it includes social skills training, parent and teachers skills training, behavioral management principles, problem-solving techniques, and also active learning methods. So, after the beginning of a treatment, we have a new problem, because we have to measure the efficacy of our treatment. So, how it is possible to measure the efficacy of a treatment? The answer is, one possible answer is single case research design. Single case research design are defined as single case research design are a diverse and powerful set of procedures useful for demonstrating causal relations among clinical phenomena. The basic design to assess a single case is a single case treatment is the AB design, where several times outcomes is measured both in A, the baseline, and B, the treatment. Obviously, there are more complex designs, such as ABA, ABAB, but the logic behind this method is the same that I will describe later. In NAD-AB design, a single case has three different effects. As you can see in the first picture, this is the effect of time on the general trend. So, in this case, this shape that we can see in the graph is just the natural shape of that behavior in the time. Then we have to consider that in a single case design there's also an effect of the treatment on the outcome levels, because obviously if our treatment is working, we can observe some behavioral change. And finally, we have also an effect of the treatment on the outcome slopes. As I told you before, these three effects exist simultaneously in a single case design. So we need a way to disentangle the role of each factors involved in a single case design. And how could be possible to disentangle the contribution of each factor? The most probably widely used technique used in the past are visual inspections. but several studies have questioned the efficacy of just the visual inspection. Because it is possible to easily make mistakes about the efficacy of a treatment. So we need also to use robust statistical indexes. Let me show an example. So in this case, we can see in this graph, the unwanted behavior seems to increase during the treatment. So we could conclude that the treatment is not working, just using visual analysis. But if we use a supported visual analysis, and at the same time we use robust statistical indexes, the result of the efficacy of our treatment is totally different. Because as you can see, the new graph, the trended graph, show that the unwanted behavior, the gray line, is decreasing. And when we apply, when we measure the effect size with the Ellison D, we can observe that the result, minus 1.32, is a large negative effect. So the treatment was effective. And so to conclude this issue, our answer about how it is possible to disentangle each factor involved in a single case design and knowing if really our treatment is effective or not, one of the most accurate way is using an assisted visual representation and robust statistical indexes. So, how the Whaam project will support this kind of process? The Whaam project will support teachers, parents, and ADHD experts to join in a network using a web application both for mobile devices and for desktop computers. And this web application will provide users with a lot of features, such as features to track observed behaviors, features to perform a functional assessment, features to plan, exploiting the expertise of ADHD experts involved, to plan a school or home treatment, and at the end, feature to evaluate using the supported visual analysis and robust statistical indexes to evaluate if our treatment is effective or not. Unfortunately, you have to wait another year to try this kind of application because our project is started just today, so you have to wait. Thank you very much.
Thank you, Gianluca, for giving us this overview about the functional analysis and the possible application in school setting. There are questions about this presentation? Okay, thank you. Yes, a question. How and when is it possible to disseminate this application at school?
I think in the middle of 2014. So you have to wait a year, more or less. And we will provide the teachers and parents of ADHD pupils with training courses to improve the teachers and parents' skill to observe unwanted behavior according to this approach, and also to use this kind of application with mobile devices and desktop computers. Obviously, this application will be translated in 4 languages: English, Italian, Greek, and Portuguese.
Okay, other questions? No. Yes. Okay, there is a dissemination plan for disseminate this application at school?
Yeah, at this moment we are defining the dissemination plan because the project started just in these days. So, but obviously there will be a lot of communication channels to be informed via social network, via mailing lists, and obviously we will contact also directly schools to inform you about the state of the project and the new events and the results.
Okay, other questions? Okay, thank you, Gianluca. Now I would like to invite the next speakers, Mrs. Andrea Bilbao from Addis Charity Association. Now we have seen at the moment an academic overview of how it is possible to treat the ADHD problems. So Andrea explained us how this association use strategies.
What we've learned from
yes,
parents.
what is learned with parents.
Yeah.
Okay, thank you.
Can I just ask, are there any parents here, parents of children with ADHD? No parents here. Oh, we have a parent there, okay. No, just to say that I'm happy to talk to any parents later if they want to talk. Okay. So we're going to look at the improvement in health of individuals with ADHD and what does that mean and why. Why are we looking at this? Because if we don't deal with these children early on, this is what happens, and this is what we found through our own research. Parents, so many parents are on antidepressants because they can't manage and live with their children. Lot of breakups in the family, divorces, separations, breakdowns. The inability to maintain employment. If you have a child with this condition, you're called to school practically every day. You have lots of doctor's appointments. Your child is sent home. It's very difficult to hold down a job when you've got a child with ADHD because they become a full-time job. And many children with ADHD are actually placed in care. They're taken away from their parents and given to other parents. The children, they develop low self-esteem, very poor relationships between the parent and the child, and also poor relationship between the teacher and the child. You know, teachers don't really like having children with ADHD in their classroom. Children don't develop good friendships. They may make a friend, but actually, you know, within a day they've lost that friend, so they don't sustain friendships. And school exclusions are just, this is the reality of ADHD. So many children are excluded from school, and this is happening all over the world. This is not just, you know, for one country. And I think that our biggest job is to keep these children in school. They've got to stay in school. They've got to get an education. Because without an education, as adults, they drop out of school. The biggest casualty of ADHD is educational failure. They start to self-medicate, turn to drugs and crime, the knock-on effect of drugs. Gambling is a big risk, poor money management, addiction to drugs, addiction to alcohol, addiction to gambling, addiction to sex, addiction to almost anything. As adults, low income or no income, inability to hold down a job. In the UK, the Home Office have told us that poorly managed and untreated ADHD is one of the top 5 causes of youth crime. As an adult, a lot of adults, their own relationships break up, they have difficulty parenting their own children, they have difficulty sustaining marriages. And then we know from 27-year longitudinal study in the UK by Professor Eric Taylor that if we don't treat ADHD in childhood, many adults with ADHD will go on to develop other severe psychiatric conditions. So, how do we get it right? Clinicians, it starts with clinicians. Are they using everything in their toolbox? You know, are they over-reliant on medication? And what that means is, you know, I'm very pro-medication, but are clinicians only using medication as a way to treat ADHD? They have time restraints, they have resources, but they don't use them, or they don't have resources. And very often they're not using the best of their resources. So we've got to look at how we get this right. What do we have to do to get it right? We have to identify what is working well for these children. And the key people involved are the doctors, the teacher, the parent, the patient. These 4 people are crucial. They have to work together, and they are partners in the management of ADHD. Because even parents, parents have a huge responsibility because they need to understand what's going on. Other professionals who come into contact with the children, as you probably know, youth offending services, the police, social workers, a lot of people involved, they need to understand ADHD. If we get it right, we can very dramatically improve the outcomes for these children. This is a survey that we held just recently this year, and one of the things last year, we asked our parents, when you received a diagnosis of ADHD for your child, were you offered a parenting course? Only 30% of parents were offered a course. Were you offered any kind of parent education course to learn more about ADHD? Only 11% were offered us. You know, parent education is probably the most crucial aspect of the treatment of ADHD. It's so important that parents understand this condition, because if they don't understand it, they cannot be part of the solution. Did your consultant give you any written information? Well, a fair number of consultants did, 64%, that's good. But you know, a lot of parents of children with ADHD don't actually read. Did your consultant allow you to choose which medication would be best for your child? Because in the UK and in America, you know, there are a lot of different medications that work in different ways, and it's really important that parents do have a say in the medication. Only 36% were involved in that decision. I'm going to show you a little case study. This is Sam. He was excluded from school for being violent towards teachers, lots of exclusions, very aggressive. He became depressed, he was suicidal, he was self-harming, falling behind at school, and his mother just felt that she failed as a parent. Now, you're probably sitting there thinking, we need to do something about this child, we need to treat him. But going back to my previous point about are clinicians over-reliant on medication, Sam actually has a diagnosis, and he is on medication, but we're still having that problem. Why is that going wrong? What are we going to do to get it right? So Mum took him for a second opinion. A new doctor who didn't just give him medication, but they talked through the medications so that Mum could understand it. They made a decision together about the best medication. She gave the mum a lot of information about the condition for herself and for school. She took time to talk to the boy to find out that he understood the condition, and she wanted to know from him where he felt he needed extra help. They were put on a waiting list for psychotherapy. They received family therapy. The doctor went into school to talk to teachers and the people in school to understand what was happening in school. The doctor actually initiated teacher training in school. She put the parent in touch with us, and she came on our parenting course. So this child was approached from all directions. Okay. So after all this intervention, this is what happened to him. His school report was brilliant. His reading and writing levels increased dramatically. He was on target for maths. And his self-confidence was boosted. His self-esteem improved. And he just went from strength to strength. School exclusions are very, very common with ADHD. And one of the problems is that parents and schools don't understand the disability aspect of ADHD. A lot of people still don't understand why this is a disability. And when we look at the executive functions in the brain, and you probably know much about this, a lot of the way the brain works creates that impairment. You know, the inability to manage time, for example, the inability to regulate your emotions and to regulate your impulses, the inability to organize your thoughts and to organize yourself. Working memory is very poor in children with ADHD, and I think that contributes greatly to the impairment of children with ADHD. When you're constantly giving child instruction as a teacher or a parent, and the child is forgetting what you're saying and they're not doing what you ask, and they get into trouble. You know, forgetting homework, forgetting to bring in their kits for PE. The diagnosis, I think one of the other problems that we have with ADHD is that very often the ADHD diagnosis comes first, but there is a huge comorbidity with autistic spectrum disorders, and very often that condition doesn't get diagnosed. So we find that we're throwing medication at children who may have both conditions, and it's not working. And you're not seeing improvement, and especially in secondary school, there's a lot of problems. And very often it takes a long time to get to the point where somebody thinks, there may be an autistic spectrum disorder here, and maybe we have to work a little bit differently with this child. So, working with parents, what have we learned so far? We've learned that parents don't like being told that they're not good parents. They don't like being told they need to go on a parenting course, because I think most of us parent instinctively. They will receive that information better if we talk about it maybe as being a parent education course, because I think that's what they need, not parenting, parent education. The usual parenting programs that parents are sent on are generic and they're far too long. Parents drop out. They're not really appropriate for the needs of children with ADHD. Because parents want, first and foremost, a tool to tackle behavior. That, I think, if we can get the behavior out the way, we can then learn to parent properly. So as an organization, what we recommend as a frontline treatment for ADHD is parent education, a psychoeducational program that teaches them about the condition so that they can better understand how to parent their child. A program that incorporates into it a behavior management program. We use something called 1, 2, 3 Magic, which is it's a behavior management program, incredibly effective, and you probably think I'm making this up, but actually it's a program that works overnight. And it's a program that can also be used in school to manage behavior very, very quickly without shouting, without yelling, and by creating some harmony in the home. There's a website there, you can find out more about it there. The other thing that we recommend is a program that can be delivered in school. It's a cognitive behavioral therapy program, solution-focused, multisensory, using visual analogies, using activities, using music, reaching children the way that they learn. The program is called Why Try, and have a look at the website. It's a program that you can use from the age of 4 up to adulthood. The aim of the program that we use is to increase the knowledge of parents, increase their knowledge, to increase the knowledge of teachers, and to empower parents to become better advocates for their child, both in school and, of course, in the community, where a lot of parents will get negative comments from their own friends. To help parents understand the disability aspect, educate parents on strategies that are really effective for managing behavior, and also to teach children critical social and emotional skills, and also this very important thing, resilience. We need to build resilience, because sadly, a lot of children with ADHD, a fair number, commit suicide. And we've just had 2 or 3 in the last year back home. So the program that we use, 123 Magic, this program, we teach parents how to sort behaviors, to understand the different behaviors, and to choose appropriate responses. There are 2 different kinds of behaviors. There are behaviors we want to stop, and there are behaviors we want to encourage. And there are different approaches for those behaviors. We teach parents and teachers to manage those difficult behaviors without the yelling and the arguing, and of course, the smacking. We learn how to encourage positive behavior through a series of rewards, encouragement, and praise. Just go very, very quickly through the program. I'm happy for you all to have copies of these slides. I'm very happy to share them with people here. So in the session 1, we will teach parents about the condition, and we will look at the positive aspects of ADHD. In session 2, we get them to think about the tasks involved about being a parent, and then what extra tasks if children are diagnosed as having ADHD. Because often parents are referred to us pre-diagnosis. This is a really good program for differential diagnosis. We look at the different parenting styles and think about which styles we're going to use and whether this is the best way to introduce 123 Magic. In the next session, we will teach them to sort their behaviors, to understand the behaviors, and also the importance of good communication, reinforcing positive behavior. Again, looking at positive behavior using rewards and praise, strengthening the family and school relationship, building self-esteem, also giving parents information about the education system because they need to understand how to advocate for their children within the education system. Sometimes you can't always rely on the school to get it right. And then we review the program and evaluate it, and then we celebrate with certificates when they've completed the program. What we've learned from these programs is that parents are incredibly resilient themselves, and they do respond well to programs that work. And if they work, they will continue coming. They benefit enormously from group work because we found that in an individual setting, it's really hard for them because they do feel very isolated. After they finish these groups, it's really important, and again, this is the role of the voluntary sector, to provide ongoing support. Because we find parents who are put onto parenting programs come back to us and they'll say, well, the program is finished, now what? I'm left alone. This condition is not curable. They're going to live with this for the rest of their lives, and we have to build up that scaffolding around these families and not pull it down. So when they come on these courses, they learn a lot of skills. We've got to keep that scaffolding in place and keep them supported. My personal journey, when my children were diagnosed when they were aged 5 and 9, they're now 26 and 30, so I've gone through all of this. My 30-year-old is a university graduate, and my 26-year-old, he's got an autistic spectrum disorder as well, so he's a bit more impaired, but he's a well-functioning, happy person. I decided to make myself as knowledgeable as I possibly could be in order to help my children. And I came up with a formula to get parents through, and I want to share this formula with you because I think it's really important to give parents hope. As parents, we have to become the expert in this condition. We have to know everything about this condition, because if we don't know about the condition, we don't know how to fight for the services and the support that they need. We have to know and understand our child. We have to become an advocate, and we're going to be advocating for our child right through up until they're an adult. They never stop being our children. Even my 30-year-old son comes to me for help and support still, and I still have to give him that, that reassurance. As a parent, we've got to be a positive role model. And the 123 Magic program actually helps us look at our own behavior as a parent and changes our behavior. Because we can't have expectations of our children if we are demonstrating poor behavior to them ourselves. So we've got to change our behavior. And I think that's the first thing that parents actually learn when they come on our program. We don't teach it, they come to that realization themselves. As a parent, we're going to have to be very patient with our children and invest in quality time, a lot of one-to-one time with our child. We've got to find their islands of competence. We've got to find what they're good at, because many children with ADHD fail in the education system, so let's find something they excel at outside of school, something we can invest in and support them with, a place where they can feel good about themselves. and they feel success. We have to support their hopes and dreams, and we have to be the shepherd that guides them, even if sometimes it may be over a cliff. This is my older boy. He's a whitewater kayaker. And from the age of 11, he started kayaking. And he went every single weekend, and we invested in this because school was a really bad place for him. But he's become a world-class kayaker. He kayaks all over the world. He makes videos, and he's done really well. So if we invest, we have a few Olympic champions who have ADHD, didn't do well at school, but are doing brilliantly in sport. So we've got to find their goals, help them find their goals, let them know that those goals are obtainable with good hard work. We've got to keep them focused on those goals, and as parents and as teachers, we mustn't give up on kids with ADHD. If we invest in children with ADHD, you get so much back from them. If we don't invest, all we're going to get is pain. The role of patient groups, this is really interesting. Parents and children spend very little time with the clinician. These appointments aren't very quick, and how many times do they see them in a year? Not very often. They spend a lot of time in the parent groups, often going to parent group meetings, maybe fortnightly, maybe weekly, maybe monthly. And yet the resources in those parent groups are very poor and very small because we don't have money. Clinicians have access to resources, but they don't spend that much time to use those resources. So what is the role of the groups? What can we do? Parents tell us that support groups have been the most important and the most helpful discipline out of all the disciplines. We need to create toolboxes that the voluntary sector can use. As a voluntary sector organisation ourselves, we've learned so much that we've developed our own teacher training programs, our own parenting programs. We have so much to offer, but we do lack the money to get these things properly manualised and put into place. We've developed psychoeducational programs, teacher training programs. I'm part of ADHD Europe, which is an association of the European patient groups across Europe, and we're doing so much now to support families and patients and teachers. We have a lot of professional members. So what are the strengths of the European associations? They have a vast amount of knowledge and skills, lots of experience of working with individuals. Working together through Europe, we're able to share a lot of information and strategies. We have a lot of professional members. We share resources. Very, very effective at awareness raising across Europe, and we've lobbied the European Parliament. Voluntary sector are best placed to educate the public. We've got more time, and we're driven by passion and not by paycheck. And I think that's really important. We work very long hours, and we work on this so hard because we truly believe that these children are worth that investment. What are our weaknesses? I think language and culture sometimes are a barrier to working together. And funding, I think that's our biggest weakness. Self-help for parents. Self-help is really difficult for parents of children with ADHD because many of them don't read, many of them have ADHD themselves undiagnosed, they can't retain information, they can't organize themselves, they can't get it together to get themselves supported. So we need to build that scaffolding around parents as well and give them the reassurance. A lot of parents, however, are computer literate, and that's a strength. That's something we need to work on. Social networking, I've been using Facebook now for the last year and various other Twitter. It's been an absolute eye-opener, social networking. I think it's been an absolute lifesaver for so many parents. They get so much help and support through joining groups on social networks. So e-learning, a really effective tool for parents, and I think this project is going to be quite good for parents. I think it's a good way forward. So a take-home message, really, we need to listen to parents, we need to listen to what they're telling us, we need to listen to what teachers are telling us, to their experience. Giving a parent a leaflet is not enough. Giving a teacher a leaflet is not enough. We need to look at the difference between the psychoeducational courses and parenting courses, what is working better. We need to make sure that parents have got skills to become good advocates. We need to give parents and teachers really good behavior management tools and strategies, really good ones that are related to ADHD behaviors, which means that teachers need to understand the behaviors. And we've got to also remember that if we are going to be giving pills to children, it's really, really important that we teach them skills as well. Because, you know, an ADHD child is like a Ferrari with bicycle brakes. Yeah? Our clinician has the power to give that Ferrari brakes. But there's no point putting those Ferrari brakes on a Ferrari if we're actually not going to teach the child how to drive that Ferrari. Okay? So those skills are the lessons we're going to teach our children to drive their Ferrari. Thank you.
Thank you very much, Andrea. There are questions about these talks. Yes, can you show the slide where is the information about the 1, 2, 3 magic approach? Yep.
That one? That one?
Yes. Okay, you have mentioned before this type of approach that you use in your association. Yeah. And what are the characteristics of this approach?
What do you mean?
In terms of parents and teacher training?
I don't really understand what you want to know.
Yes. It is a behavioral management program.
Yeah.
Okay.
It works on some interesting principles, and it works on principles that actually go against many parenting programs. Because the 1, 2, 3 magic approach, how it works is, we call it a no talk, no emotion program. It stops parents yelling at their children, so we don't talk to them. There are various strategies that we use. We train the children to do what we want them to do, to get the behavior under control. And while we're training them, we don't have conversations. If you start an argument with your child, just say your child is jumping on the sofa, and you want your child to stop jumping on the sofa, and you shout, most parents will shout, get off the sofa, and the child will shout back, I don't want to get off the sofa, I want to jump on the sofa. And then you shout back at your child, don't you jump on the sofa, you're a naughty child, and I'm going to put you on the naughty step. And you get this interaction that goes on until it ends up with screaming, yelling, and possibly hitting. Because the minute you engage in that kind of talk, you're inviting that response from the child. So we use it's a time-out approach. The child is going to get 2 chances to stop jumping on the sofa and will then go to time-out. And we don't have a conversation about it. And when they come out of time-out, whatever's happened, we don't talk about it. It's finished. It's a clean slate. We move on. We have a smiley, happy face. Okay? Because we're training them. And it's not that we don't ever talk to children, but the program has so many different components. The first part is how we stop that difficult behavior. The second part is how we encourage the positive behaviors, like making your bed, doing your homework, tidying up, your chores, going to bed, going to school, getting dressed. And then the third part is how we talk to our children, how we work as a family meetings, having fun with our children, enjoying them. But it's a brilliant program because you can stop a child in a classroom. Teacher can stand here in a hall and can stop a behavior at the back just by holding up one finger. But that's why it's called 1, 2, 3 magic, because it works. It's 2 days of training. I couldn't possibly share it all in one go, but it's okay.
Thank you. Other questions? Okay, thank you, Andrea, for your talk, and I present the next speaker. Gavin Doherty from Trinity College. The name of his
Well,
talk is...
it's different to that. So,
Yeah.
bring it up in a second. Well, just slightly.
Okay. His technology to support mental health, engaging teenagers with psychotherapy using mobile phones. Thank you, Kevin.
Okay, so I think that's going to be a hard one to follow. It's a very interesting talk there. I'm mostly today going to talk about work that was done together with Mark Matthews, who was a PhD student of mine, now postdoc, split between Cornell University and Trinity College. So we've been working to develop technologies to be used to support mental health treatment for a number of years. So why are we trying to do this, first of all? I mean, if there's no major problem, then maybe we don't need to interfere using technology. So first of all, as we're all aware, ADHD being part of the overall problem of mental illness, but many countries and services, health services, are struggling to meet the demands placed on them in terms of mental illness. So this is a problem of access. A lot of people just can't get access to treatment. Secondly, then, partly due to the stigma surrounding mental illness, is even where appropriate treatment options are available, a lot of people are unwilling to engage with services. So they really, until they get into a very bad state, they really don't want to go to a service. And finally, even where people have decided to seek treatment, they might find it difficult to actually engage with the treatment or to maintain adherence to certain things that they're supposed to do. So this is the issue then of engagement. So we've got access and engagement as being big problems. And of course, when we talk about children and adolescents, both of these actually can be worse. Certainly the child and adolescent services that we've had contact with seem to be very overburdened in terms of their workload, and they've got a lot of difficulties engaging young people with treatment. So the challenge then is a quote here from Kasdan saying it's to involve the child in treatment and to work toward a change that the child may not view as necessary or even potentially useful. So this is a tricky problem and something maybe that we can help to address using technology. So children, first of all, are not really used to talking about their kind of innermost thoughts and feelings, and particularly doing this with a stranger is a very difficult thing to ask them to do. As I've mentioned, therapists can often be overburdened, and so having a child sit there with their arms crossed, not saying much for several sessions is not really a great use of resources. And also there's the perception on the part of the children and adolescents that these paper-based materials are kind of outdated and not very engaging to them. So we've looked at a couple of different ways of engaging young people with psychotherapy. So we did a series of projects around the area of therapeutic games, so taking psychoeducational material and strategies and embedding them into a computer game where the child goes around, meets various different characters, has conversations with them. The characters introduce videos, they fill in questionnaires, they answer questions and so on. So the initial game we did was called Personal Investigator. It supported brief solution-focused therapy. After that, we built a tool to allow therapists to author games, and so we had cognitive behavioural therapy games that try to communicate the essential concepts of CBT to children, which are not necessarily easy for them to grasp. And really we were trying, firstly, just to act as an icebreaker. So if you get the child talking, maybe you don't need the game after the first session. That's fine. But as we got into it, we found that actually the game could help to open up the therapeutic space a bit, help to build a therapeutic relationship and to provide a context and in some cases a language for conversations then with the therapist. So that's within the sessions where the child sits down next to the therapist and plays the game. We've also looked at a slightly older cohort in terms of young adults and so on, at engaging people in online treatments. So these can work if people actually do them, but if you just point at somebody at a computer system and say, off you go, they're likely not to do it. So we've looked at computer-supported treatments where there's feedback from a real person, so a psychotherapist, a psychologist, or a trained support worker. What I'm going to talk about today, however, is engagement in activities than between sessions. So this is a kind of simpler example to talk about. So the idea here is that if we engage young people more in their own treatment between the sessions, get greater adherence to therapeutic activities, well, that in itself could be a nice outcome, but this could also lead to a greater sense of self-efficacy. They're successfully carrying out these things. They've some element of control over the therapy, and this in turn can lead to positive outcomes because self-efficacy is associated with better outcomes. So the example I'm going to talk about is mood charting. So this is something that's used by several therapeutic approaches, so it's a flexible tool. We don't need therapists who are committed to some specific approach to therapy. It's used for a range of different disorders, including, in some variants, ADHD. With mood monitoring or mood charting, the child is self-recording their own emotions and maybe things like sleep, energy levels, and so on. They record these feelings, and in the past this has been done with paper diaries. So if this is done, then this provides information to the therapist or psychologist, maybe making decisions on medication, for example. For the person themselves, they might be able to identify changes or patterns kind of in their own behavior, so develop greater self-awareness. Having this material before the child goes into the session can help to save session time because they're not trying to reconstruct, you know, the previous period, or can provide cues as to interesting things maybe that should be asked. And it gives access to this sort of invisible time between sessions. So again, if paper charts were working fine, there would be no point in looking at technology. But it turns out there are a lot of problems with paper. So the major problem is low adherence. So they really tend not to be filled in very often. In the case of children, they tend to be lost, or they're terrified somebody's going to find it. So they don't typically get carried out very reliably. So Stone did a study with instrumented diaries which found an adherence rate of 11%. Okay, this was quite different to the reported rate where people said they were doing it, but in reality they weren't actually doing it very often. If you want to gather some corpus of data, let's say for decision making, then somebody's got to type in all of this information, so that's pretty time consuming, and the therapists we work with typically don't have time to do that. It's difficult to assess the reliability of the data. These charts are often retrospectively completed just before somebody goes into a session. So they want to please the therapist, so they fill in some data based on the recall, but this is probably not very accurate. But there's no way to know. You know, have they really done this every day, or did they do it 10 minutes ago? So in practice, people told us that this was often done by parents or not at all, and for children, there are associations with school, basically. It's a paper and pencil exercise, that equals homework, and not generally something they're interested in. So we thought, well, why not put this on a mobile? It's an easy thing for us to do from a technical perspective. It's a simple thing to try out, and maybe we can explore this space between sessions a bit. So young people told us that really mobiles were something that was, you know, very personally meaningful to them. So they said it was closer to the heart than any paper diary. Among the people we were working with, we did a little survey to get some direct feedback, and 19 out of 20 owned a mobile. The surprising thing, really, I suppose, these days was that one of them didn't. Part of the potential advantage of the phone is that it's a very private device. So a child could be filling in a diary on the phone and nobody knows what they're doing. Whereas if they're filling in something on a paper chart, somebody might be curious as to what's going on. It's convenient, so a child is not necessarily going to carry around pencil and paper the whole time, but is very likely to have the phone with them at all times. So if you want to capture maybe mood after anger episodes or something like that, again, this approach to charting has this availability and convenience. And again, there was this school association. When we presented this idea to children in terms of the paper chart versus the mobile chart, in which they prefer, they just said, well, that's a stupid question. You know, the mobile is clearly superior. Things on paper are like schoolwork, and on the phone, it seems less like work to them. So the implementation was pretty simple. We did this quite a number of years ago, so this was before the smartphone era, so we had to build a Java application for the phones. We sent out reminder messages to the phone via an SMS gateway, so that's turned out to be quite effective, and the content of the diary entries then came back in over a web connection. So the client then would start the application, enter their PIN, fill in their mood on a visual scale, chart their energy level, the amount of sleep they'd had, and put in a little text entry on how they were feeling. That was then sent to the server, and they could review kind of previous entries they put in. So on the server side then, we did a web interface so people could look up charts then of their data. So I work in the area of human-computer interaction, and we're generally concerned with building systems that people can actually use. And the basic technique that's used for this is called user-centered design. And as you might guess from the name, it involves getting a lot of feedback from end users, preferably observing them using systems and so on. And this is a bit of a challenge in this area. When you're talking about clinical sessions, we can't really sit in on the clinical session kind of watching them talk about or listening to them talk about the diary. We can't follow the child around for weeks to see the occasional moments when they use the diary. So it's a slightly challenging setting for us to explore. Another issue is because of the ethical aspects of this, we really didn't want to be trying something in a clinic until we were pretty sure it would work. Okay, so we need to build up some confidence in the technology first. And a further difficulty then is therapists tend not to be very confident with technology. So really we were dealing with a very low level of experience with technology because simply in the past there haven't been a lot of tools that they would use which would be technology based. So the process then we went through to try and deal with some of these issues was to start with a simple usability trial where we're trying to make sure that the application can be used by the average person, that there's nothing confusing about it. The next step then was to try and build up some confidence that this was more engaging than paper-based diaries with a non-clinical group before moving on then to the clinical evaluation. Obviously with the usability trial and the engagement trial, we wanted to pick people who were as close as possible to our target group, as it were. So we worked with people from the same areas, the same socioeconomic backgrounds, the same ages. So with the usability evaluation then, we did this at an after-school computer club in a fairly deprived area in the centre of Dublin, with a number of 12 to 14-year-olds using their own mobile phones. And we were able to use this to identify things about the application that were hard for them to understand or which weren't very usable. Following this then, we did a school-based study where 2 schools were given a paper diary where the children were asked to fill out a diary entry every day, and 1 school, the children were given the mobile phone version of the diary. So first of all, you see that of 52 paper diaries we gave out, 18 were recovered. So this would be about the norm for paper diaries. So you're going to get very few of them back in the first place before you can even start looking at how many of them have got entries on them. Whereas with the mobile diary, 17 of these were recovered, and the ones that weren't recovered were because those children just weren't in school that day. Okay, so we're looking at a very high recovery rate there. Within the recovered diaries then, there were significantly fewer entries on the paper diaries compared to the mobile diaries, and also children pretty much admitted with the paper diaries that they'd filled in entries just before they'd arrived. Whereas with the mobile phone-based diary, we had timestamps associated with every entry, so we knew exactly when all of the entries had been made, and they'd been all made on the individual days. In some cases, actually, there were more entries on a given day than we'd asked for. So some children really started engaging with this as a tool themselves. What came away from this, obviously, we had some data which suggested adherence could be pretty good, but also the mobile diary was seen as being as easy to use as paper. They didn't see any difference. And given that paper is pretty easy to use, that was a good result. The other thing that came back out of it, even though this was a non-clinical setting, was that privacy was very important to them. So perhaps we could expect that in the clinical setting, but to get it already in this setting was maybe slightly surprising. So I'm going to talk then about the first small clinical pilot that was done in public clinics where people were used to use it across a minimum of 2 therapy sessions. And so our notion was that maybe over kind of 7 or 14 days that the diary would be used every day by the people involved. So we had 10 participants with a pretty wide cross-section of issues, and this was fairly representative of the caseload of the service that we were working with. So they weren't cherry-picking easy cases by any means. There were some very difficult ones mixed in here. Adherence then actually turned out to be even better than the school-based trial that we'd done, which, given the difficulty of some of these cases, was perhaps surprising. So participants really became engaged in monitoring their own feelings and their own mental health. But what came out of it as well, though, was that people were reflecting on the data as well as creating content that would be used in the therapy sessions. If we chart out the actual patterns of usage, so across the bottom is days, and so we've got a vertical line for every day that the diary was used. First of all, you'll see the surprising thing is just the size of the numbers along the bottom. So we expected this would be used for 7 or 14 days, and one client used it for about a year. So our adherence rate becomes a lot more impressive when you look at the scale of this. But also we see there's a number of different patterns. So client 4, for example, actually is using it on a fairly regular basis, but just not every day. So, you know, we can't interpret low adherence values overall as necessarily indicating that it's not working. That does seem to be working pretty well for that client. The other surprising thing was the number of complete entries, as in every data field was filled in. So somebody could not fill in a text entry and just send in the numeric data. But actually, there were a lot of text entries completed, and this was also a surprise to us. So let's talk about a couple of case studies then, just to delve a little bit deeper into the nature of the use of this kind of tool. So Philip was aged 10, presented with low mood and thoughts of suicide. This is the example where the usage was actually fairly consistent, but not every day. And 78% of his entries included some text, okay, so some comment on his feelings. So the feedback then, following use of the tool from the interviews, was that the diary certainly helped recall that certain episodes initially he couldn't account for, so in terms of, you know, points where they were very low mood, but that by reviewing the text entries and so on, he was able to reconstruct what had happened. Okay, so again, it's supporting those conversations within therapy. Also, there was disclosure of details the therapist wasn't aware of in the text entries, and actually there's what's called this online disclosure effect, where people are often more honest when entering information into a computer system than they will be initially talking to a professional. So that seems to be emerging here as well. And overall, it was rated as being very helpful. Another case, which is quite interesting here, Beth was 13 and a suicide risk. In this case, the therapist thought it might be useful if they also charted the mother's feelings. And so she started using the diary, and they were able to use that information then to have a conversation about how the mother's moods were being affected by Beth's moods and behaviours, and that there was a much closer relationship there than they'd considered. And so that really opened up a very interesting conversation in therapy. Beth was on antidepressants here, which were actually affecting her ability to recall details, and so the diary again was really supporting them in reconstructing what was going on, because she just couldn't remember straight off things that had happened. And in this case, there was a very close correlation between the SMS reminders that were sent and when the diary was actually filled in. So it was supporting us in providing this facility to remind people to fill in their diary. I should say as well, actually, with respect to the SMS reminders, we didn't want people receiving impersonal reminders, so they would compose the reminder message themselves with the therapist in the first session where the system was introduced. And so that's a protocol we've actually repeated in other settings. Again, to illustrate, this wasn't being used in easy cases. Another child, Barry, had a long history of engagement with the service. He'd been hospitalised at one point, and he had a history of poor adherence to therapeutic tasks that had been set. So this was an interesting one because over the period of usage of this, he disengaged for a while but then re-engaged, and so again that's a pattern we might want to think about. But he started doing very detailed kind of text entries, journaling really how he was feeling, and this became a really important activity to him, and he had very high adherence to doing this. What was very interesting in this case is that he used then this journaling process to raise embarrassing issues that he didn't want to raise directly with the therapist. So the therapist, on seeing this information, would ask a question about it, but Barry didn't have to bring it up himself. So again, it's a slightly more nuanced view on what's going on in the therapy sessions that we're getting through this probe with our technology. Another thing that started to happen was that rather than going to the website to view the charts, Barry kind of took ownership of the whole process and would start kind of showing entries on the phone to the therapist. So again, we thought this was an interesting aspect of it. And the graphs, which we'd added, again, as an exploratory thing within the technology, turned out to be pretty significant in many cases. So privacy, once again, turned out to be an issue. So we'd added a PIN code when the application was started up so that nobody could accidentally go into the data. But initially we'd had a little icon and the name of the application when it was installed. And even this was too much for people. They were very, very concerned that somebody else would look at their phone. And young people do hand their phones to each other fairly regularly in terms of looking at photos and so on. And so this was an issue. So we had to change that to something completely innocuous, so MD and no icon, so that nobody would know what the application was. So it really needs to be inconspicuous. So you would have to be very careful about the use of audio, for example. But also, what we found in a number of dimensions was that giving people some sense of control was important. So for the website with the graphs, it was the child who held the password for that. And then in the therapy session, they would go in and log on to the site. And so, again, giving them some sense of ownership there. So graphs turned out to be a lot more important than we'd realized. In one case, actually, it was a multidisciplinary team that were dealing with treatment, so psychiatrists, psychologists, social workers, and so on. And they actually taped together all of the individual charts to have a kind of longitudinal kind of record of what was going on. And this was used in case discussions and with discussions with the child and with the parents themselves. So again, we'd expected this would be used over the course of 2 weeks. So we weren't expecting that people would be looking at months and months of data. So it's a nice example of them appropriating the technology and using it in their own way. As I mentioned, there were a number of interesting things that emerged with respect to broaching difficult topics and so on, and the graphs on the phone, which we'd added as an afterthought, turned out to be used on a fairly regular basis. It's worth remembering that no one approach, and particularly technology approaches, nothing's going to work for everybody. So you should always consider providing people with different options. So some people just don't want to do this on their phone. Some people might have difficulties getting kind of coverage if they're living in a very rural area, but also some people mightn't like their phone associated with their treatment. Okay, that's a barrier that they didn't want to cross, and so there should always be alternatives we're providing to people. So since then, obviously, the world has moved on in terms of technology. It was nice to be first into this area, but actually it turned out to be very difficult to do wide-scale deployment on the previous generation of mobile phones. the way applications would install was different on every single handset on the market. So really it was a nightmare in terms of trying to do any larger studies. But obviously now, with smartphones and web-based applications, really it's become a lot easier to do this kind of work. And there are lots and lots of diary applications out there now you can download yourself. We've done work ourselves on flexible diary systems. So some therapists came to us and said, well, could you do a diary with a substance abuse or alcohol abuse element to it, or an anger management diary, and so on. So really, we need the ability to flexibly produce different diary systems. In terms of future work, obviously, it'd be nice to do some larger trials now that we've re-implemented things using HTML5 and web applications. That's going to be a lot easier for us to do. Obviously, in the context of Whaam, it would be nice to explore some ADHD-specific issues here. And we've got a project around bipolar disorder where we're going to be looking at sensor data, which might be informative for people. So this can be obviously movement data. The phones can record a lot of things at the moment, but also soft sensing. If somebody is checking their email every 2 minutes, it might indicate, okay, that they're an academic, or it might indicate, if they've got bipolar disorder, that maybe there's a manic episode approaching. So there could be, useful information about triggers that we could pick up from that. Okay, so I think the conclusions here I've gone through already, and so overall, I would say that we found that mobile phones can help to engage young people in therapeutic activities between sessions. Thanks.
Thank you, Gavin, for giving us this overview about mobile technologies. And there are questions about this talk? Okay, thank you, Gavin. Okay, the next speaker is Monica Maia from Porto Polytechnico of Portugal, and he's talk about distance education for development training program in special need education. Thank you, Monica.
Thank you. Okay, good morning. I and my colleague Rui Teles are here representing Inclusive School Support Unit from School of Education of the Polytechnic of Porto Institute from Portugal. And we will present distance education for development of a training program in special education needs. Well, in the first part of this presentation, we intend to discuss the considered key principles for training programs that aims to support or reinforce inclusive profiles. In other words, in the first part of this presentation, we tend to discuss the underlying principles for training programs focused on turning people capable of implementing best support strategies for children to participate. In the second part, we intend to mention how to turn workable this education model for inclusion through distance education devices. So what are the grounds for our education model for inclusion? Well, as you know, inclusive education is an ongoing process that aims to offer quality opportunities for all to learn and participate. And therefore, we have to, or it implies, to respect and respond to different students' characteristics and needs, and to know how to read the interaction between these characteristics and the surrounding environmental factors or events. As represented on this picture, on the basis of any development in the society, we have a triology established between research, innovation, and education, where, in fact, research can be seen as the factory for innovation development, which outputs cannot be seen without considering the implementation field. So considering that inclusive practices are ethical ways to act, then when we think on research and innovation outputs on inclusive practices, we should think on it as an interaction process between knowledge and a set of beliefs and values that also commands human practices. Then, considering education sphere as a mediator between research and innovation dimensions and real practices outputs, then we should think on education for inclusion, or we should think on it as a gestalt between scientific knowledge and values. And this way of thinking on the education for inclusion is clearly reflected on World Bank directives, where teacher training should not only acknowledge knowledge and skills dimensions, but also professionals' attitudes and values. As stated, the principles for inclusion should be built into teacher training programs, which should be about attitudes and values, not just knowledge and skills. Considering this, or recognizing this complex interaction between different elements, there have been international efforts, namely conducted by European Agency for Development in Special Needs Education, in order to find out a set of core values and competences that are aligned to inclusive profiles, which have been framed in the last decades into person-environmental fit approaches that are grounded in a multidimensional understanding of students' functioning in order to implement a continuum of supports. Well, by this inclusive profile is by these agency lenses seen as being built in core values, in 4 core values, that is valuing learning diversity, supporting all learners, working with others, and personal professional development. And these core values are associated with teachers' competences areas that are made up in 3 main elements: attitudes or belief demands, knowledge or level of understanding, and skills to implement the knowledge in a practical situation. So based on these metrics, a positive interaction between the triology established between research, innovation, and education implies that academic staff and trainers conceive the training programs as an appropriate space to bridge or to create bridges between the research knowledge and the practical inquiry, that is, situational needs and challenges that professionals face on their daily practices. Establishing a constant connection between propositional, procedural, and situational knowledge is the structural principle of our education model for inclusion. And having this in mind, our theoretical assumptions for education model for inclusion is then that training teachers is training people to work with people, and therefore requires working with values, and therefore we should be able to help teachers to look at the educational reality through the lenses of human rights and values. And if we want to turn all contexts habilitated to receive all students, we also should be able to help teachers to stop playing the game of finding differences and start playing the game of finding the equals. In other words, we should be able to educate for teachers to become experts of support and not to become experts in micro areas of impairments. Well, the pedagogical implications of these theoretical assumptions are then that we should, in any training program, to have a start point, teachers' practical situations or teachers' problems and challenges as essential triggers for change, and we should explore extreme situations to acknowledge these situations through the eyes of the knowledge based on research. is of these constant connections, on the need of this constant connection between propositional, procedural, and situational knowledge that we intend to conceive and build the education devices or the distance education devices that now Rui will talk about.
Okay, I'm supposed to assure the practical aspect of these matters. Let me just show you first what we do, because we work with assistive technology at the School of Education, and we will get there because after all, we're talking about distance education, and distance education is also, we can also consider it as assistive technology. Of course, there's a lot of things we could do, talk about assistive technology. We don't have much time. I just want you to show you that in terms of technical components, we work with communication, mobility, manipulation, and orientation devices. That means that we work with interpersonal communications for alternative communication, PC accessibility, telecommunications, web accessibility, reading and writing strategies. This is very important also for learning difficulties. Of course, we also have other values in mobility. We explore everything about manual and electronic mobility for accessibility, where at the homes, adaptations for vehicles, sports, games, positioning, sitting, and also we study many aspects related to adapted tourism. We also have areas in dressing and clothing, eating, hygiene, and domotics for manipulation. And what is more important for us is in terms of orientation for blind, guide dog, early intervention, and this is the point where we want to get, the cognitive aids and behavior aids. So we work a lot with learning management systems, and it's these learning management systems that we are going to do next in the project. So we are supposed to do a training program and a training course, which we mean to do in a B-learning system. That means a mix of presence and distance training. And we are also supposed to build an e-learning module to provide behavior modification techniques based on social learning and the use of web applications for this project. That means that the web application is going to be assessed by all kinds of persons, especially by parents and teachers. And we are supposed to create a virtual environment that means a training system where parents and teachers can access, and also for higher education students, teachers, and all experts working with ADHD students for a training and structured model. That means that this learning management system will be a kind of a collaborative learning system where instructors and all partners of the project are going to participate, and so we will build a virtual community. So in terms of technical components, we will use a learning management system like Moodle. Maybe we will have a front end like Joomla. Of course, this is rubbish for you. Chat for synchronous communication, forums, journal, glossary, lessons, web quest, database, comms, and we are going to build learning objects so that we can perform all technical aspects. In terms of human components, We know that we have more efficient tools with the learning objects for the training. We will have better communication, we hope, for synchronous and asynchronous communication. It is supposed that we have webinars, and time management is also something that is very positive in this kind of in this system of learning. Of course, we'll have to take in consideration something very important. For example, the digital literacy of the learner. Most technicians or most teachers don't have much literacy, digital literacy, which causes most of the time anxiety and emotional constraints. That means that we have to overcome these conditions. Besides, we have to pay attention to the cognitive style of the persons and especially use universal design for learning in multimedia. That means all supports will be very useful for what we want. And also, of course, socio-economical variables. So this is all the component of the distance education, which is the complement, I complement with what Monica said, and what we really want is to build a real virtual learning community, and we hope this is very successful for the project. So this is very short. Thank you very much.
Thank you, Manuel and Rui. There is questions about this talk? Sì. Ok.
Appunto, oramai siamo pochi, siamo rimasti in pochi. Volevo sapere, io non so come sono le condizioni scolastiche in Portogallo, in Grecia, in Inghilterra, in Irlanda, non so come funzionano. Non so se loro sanno come invece vanno le cose qui da noi. Quindi, cose molto belle, troppo belle forse per la nostra scuola. Quindi un invito a creare degli strumenti però sulla realtà effettiva della nostra scuola. Noi abbiamo le classi con 25-30 studenti, classi fredde, senza riscaldamenti, gli alunni che scappano dalle finestre, di notte vengono e ci fregano i computer, ci vandalizzano tutto quanto. Quindi questa bella teoria però che venisse ad avere, insomma, cioè che potessero scendere loro con i piedi per terra, perché insomma qua le cose non sono purtroppo così belle. Quindi un invito a studiare le nostre scuole per poter fare tutto questo.
Okay, thank you very much for the participation to this session, and I have a pleasure to special thanks to all participants of this session. We have seen an overview of the problem and behavior problem of ADHD and how the technology can support this problem. So thank you very much for your participation. Outside of the room you can find the certificate of attendance, and thank you very much